Hello my dear friends. So as a part of the continuation of the endocrinology, in this session I will be discussing this very important topic, that is the acromegaly. So acromegaly, it is a clinical condition which is characterized by increase in the growth hormone. So if you take the basic physiology of the growth hormone and the regulation of the secretion of the growth hormone, it is mainly from the anterior pituitary. Yes, so this is a classical presentation in patients with the acromegaly. So you will have this particular broad face and as well as you will have the prognathism. And even if you take the nose of the individual, like the individual will have a very broad nose. So this will be the classical presentation in patients with the acromegaly. Now, first of all, you should be able to differentiate acromegaly and as well as the gigantism. So we have two important terminologies called, number one, gigantism, and the other important terminology is your acromegaly. So gigantism, it is a clinical condition where there is increase in the growth hormone before the fusion of the bones. Right, so that is what is your gigantism. Whereas you take acromegaly, it is also the clinical condition which is characterized by increase in growth hormone, but that is after the fusion of the bones. So in the sense, gigantism is a clinical condition which will occur mainly in the children due to increase in the growth hormone, whereas acromegaly, it is a clinical condition which is commonly seen in adults. So acromegaly is a syndrome of excessive secretion of growth hormone, right? Excessive secretion of growth hormone. And this acromegaly, it is an insidious chronic debilitating disease associated with bony overgrowth and as well as the soft tissue overgrowth. So please remember, in acromegaly there is bony overgrowth and as well as soft tissue overgrowth. That is what you will see in acromegaly. And these patients with acromegaly, there is high chance of mortality because of the bony overgrowth and as well as the soft tissue overgrowth. Now, what are the causes for the acromegaly? Now, before going into the etiology of the acromegaly, first let me discuss the regulation of secretion of the growth hormone. So, growth hormone is the very important hormone which is produced from the anterior pituitary. Now the growth hormone which is synthesized in the anterior pituitary, it is released from the anterior pituitary that will go and act on the target tissue. Please remember, the target tissue for growth hormone, it is liver. Right, the target tissue for the growth hormone is the liver. And when the growth hormone comes and acts on the liver will produce somatomedins. Somatomedins, they are nothing but your insulin-like growth factor. Right, somatomedins, they are nothing but your insulin-like growth factor. And these somatomedins, whenever they are produced from the liver, they will go and act on the target tissues like bones and as well as the soft tissues. So please remember, the physiological action of the growth hormone is through somatomedins or the insulin-like growth factor. Now, the anterior pituitary which is synthesizing the growth hormone, it is completely under the control of your hypothalamus. Hypothalamus will release what is called growth hormone releasing hormone. Growth hormone releasing hormone will go and stimulate the anterior pituitary, and in response to that, the anterior pituitary will release this particular growth hormone. But for suppose, if there is excess amount of growth hormone, if it is produced, then this excess growth hormone will go and act on the liver and there will be excessive release of the somatomedins. Right, there will be excessive release of the somatomedins. This excessively released somatomedins, right, this excessively released somatomedins that is insulin-like growth factor, that will go and act on hypothalamus, and it will stimulate the hypothalamus to produce somatostatin. Right? It will stimulate the hypothalamus to produce somatostatin. Or what it will do is, this excessively released somatomedins, this will go and inhibit, right? This will go and inhibit the growth hormone releasing hormone secretion. So, two mechanisms which will suppress the growth hormone secretion if there is increase in your somatomedins. Number one, it will stimulate the release of somatostatin. What the somatostatin will do? Somatostatin will inhibit the secretion of growth hormone from anterior pituitary. That is one thing. Second important thing, that increased somatomedins will inhibit this growth hormone releasing hormone secretion from the hypothalamus. And the third important mechanism is, this increased somatomedins will also inhibit the anterior pituitary, and thereby the growth hormone secretion does not occur. So what I mean to say now is, whenever there is increase in your somatomedins, number one, they will go and stimulate the hypothalamus to produce somatostatin, and thereby the growth hormone secretion will be inhibited from anterior pituitary. Number two, somatomedins will go and inhibit the hypothalamus, and thereby growth hormone releasing hormone secretion will not be there from hypothalamus, and thereby there is no growth hormone secretion from anterior pituitary. Number three, this increased somatomedins will go directly act on anterior pituitary and will inhibit the growth hormone production. So in this way, the growth hormone levels are being maintained adequately. Now, if you take the causes of acromegaly, the causes of acromegaly could be, number one, due to excess growth hormone secretion from the pituitary abnormality. Right? Due to excess growth hormone secretion from the pituitary abnormality, that is your pituitary tumors. Or this excess growth hormone could be due to the abnormality within the hypothalamus, that is excess GHRH hormone secretion, excess growth hormone releasing hormone secretion. Now, what are the conditions which will cause excess growth hormone secretion? And what are the conditions which will cause excess growth hormone releasing hormone secretion? Now, let me tell you both of them. Now, you see this table. The conditions which will cause excess growth hormone secretion is the pituitary abnormality. And what is that particular pituitary abnormality? That is somatotroph type of pituitary adenoma. Right? And this somatotroph type of pituitary adenoma is the most common cause for your acromegaly. And apart from your somatotroph type of pituitary adenoma, the other causes include mixed growth hormone cell and as well as the prolactin cell adenoma. So, in this scenario, where there is mixed growth hormone and as well as prolactin cell adenoma, the individual will land up in what is called somatotroph type of pituitary adenoma. Right? Somatotroph type of the pituitary adenoma. So, what you need to understand here is, in case of somatotroph type of pituitary adenoma, there is hyperprolactinemia and as well as increase in growth hormone production. That is the second most common cause for your acromegaly. And the other causes for excess growth hormone secretion include somatotroph cell adenoma, right? And so this somatotroph cell adenoma and as well as mixed growth hormone cell and prolactin cell adenoma, like you have very nearby clinical manifestations, right? More or less similar clinical manifestations, except there will be difference in your histopathology, right? Next, and the other etiologies which will cause excess growth hormone secretion is the plurihormonal adenoma, growth hormone cell carcinoma or metastasis, multiple endocrine neoplasia type 1 where you have growth hormone cell adenoma, because in multiple endocrine neoplasia type 1, in MEN1 syndrome, you have 3 P's, right? So what are these 3 P's of your MEN1? That includes the pituitary abnormality, that is your pituitary adenoma, right? And second important abnormality is parathyroid abnormality, right? That is parathyroid adenoma. And the third important abnormality is the pancreatic adenoma. So what is that pituitary adenoma of your MEN1? One, it can be growth hormone cell adenoma. See, the pituitary adenoma, it can be of any type. It can be like somatotroph, it can be like prolactinoma, anything. But one of the type of pituitary adenoma is the growth hormone cell adenoma, which can also make the individual to land up in acromegaly. And the other condition which can cause excess growth hormone secretion is McCune-Albright syndrome. Then we have ectopic sphenoid or parapharyngeal sinus pituitary adenoma, and then extra pituitary tumors, that is pancreatic islet cell tumor and as well as lymphoma. But these are like rare condition causing acromegaly. So these are all the clinical condition. These are all the clinical condition where there is excessive growth hormone secretion. But if you see these conditions, there is excess growth hormone releasing hormone secretion. Now this excess growth hormone releasing hormone secretion, you have central pathologies and as well as the peripheral pathologies. Now what are those central pathologies? The central pathologies include hypothalamic hamartoma, choristoma, and then ganglioneuroma. So hypothalamic hamartoma, choristoma, and as well as ganglioneuroma, please remember the condition, it is very rare, right? Less than 1%, right? Less than 1%. There will be excess GHRH secretion, and that will lead to excess growth hormone secretion. And you have peripheral causes where there is excess growth hormone releasing hormone secretion, and these peripheral causes include bronchial carcinoids, pancreatic islet cell tumors, small cell lung cancer, adrenal adenoma, medullary thyroid carcinoma, and as well as the pheochromocytoma. So these are the conditions where there is excess growth hormone releasing hormone secretion. So these are all the causes for your acromegaly. Out of all these, which is the most common cause? Please remember, it is densely or sparsely granulated growth hormone cell adenoma. This is the condition which will cause excess growth hormone secretion. Now, after having discussed about the etiology of the acromegaly, let me take up the clinical manifestations. But remember, the most common cause, what is that I have taught you? It is somatotroph type of pituitary adenoma. Now this somatotroph type of pituitary adenoma, it can be microadenoma or macroadenoma. Let me discuss that. So somatotroph type of pituitary adenoma, it is the most common cause for your acromegaly. This somatotroph type of pituitary adenoma, please remember, depending upon the size, right, it can be microadenoma or macroadenoma, right, it can be microadenoma or macroadenoma. So microadenoma, the size of the tumor is less than 10 mm. Macroadenoma, the size of the tumor is more than 10 mm. You take in case of prolactinoma, which I have discussed in the session of the prolactinoma. What did I teach you there? Microadenoma is more common than macroadenoma. But whereas here, in case of acromegaly, please remember, it is your macroadenoma which is more common than compared to that of your microadenoma. That means whenever there is macroadenoma, the mass effect will be more. If there is macroadenoma, mass effect in the sense, the effect on the surrounding structures, right? And if you take the clinical finding in these patients with the acromegaly, growth hormone excess occurs most frequently between 3rd to 5th decades of life, right? So between 3rd to 5th decades of life, growth hormone excess occurs most frequently. Now, whenever there is growth hormone excess, there can be skeletal changes, right? And there can be also soft tissue changes, right? Both, because the somatomedin which is released in response to your growth hormone on the liver, the somatomedin will go and act on the skeletal tissue and as well as the soft tissue as well. Now, if you take the clinical manifestations, like for example, you take the skeletal manifestations first. So skeletal manifestations, please remember, length of the bone will not increase in patients with your acromegaly. Why? Because acromegaly is a clinical condition where there is increased production of your growth hormone after the fusion of the bones. So length of the bone will not increase. It is the breadth of the bone which is increased. So there will be like broadening of your hands, there will be broadening of your feet, right? And even you take the facial features, they become very coarse. So these are the skeletal changes. So if you take the hands, they have broad hands and as well as feet. And if you take the finger, the breadth of the finger is also increased. So thereby the ring, it becomes very tight, or the ring size is increased. And if you take the facial features, they have coarse facial features, right? They have coarse facial features. And even your feet, the breadth of the feet is increasing. So thereby what will happen to your shoe size, right? The breadth of the feet is increased, so the shoe size is also increased. Okay. And even you take the head circumference, the head circumference is also increased. So please remember, as the head circumference is increased, the hat size is also increased. So that is the reason why this is called, right? There is a terminology given to this particular disorder of acromegaly because of frequent changing of the hat, because of increase in the size of the hat. So this is called Englishman changing hat disease. Right, this is called Englishman changing hat disease. Now we need to discuss about the facial features. Right, so if you take the face of this individual, like I said you, there will be coarsening of the facial features. So you take the nose, right? The nose, it becomes very broad, right? And you take the mandible, right? There will be forward protrusion of the mandible. So this we call it as the prognathism. Right, this we call it as the prognathism. And within this mandible, there will be separation of the teeth. Right, within this mandible which has been protruded forward, there will be separation of the teeth, right? And even the mandible is also enlarged. And apart from that, you take this vocal cords, the vocal cords, they get enlarged, or the vocal cords, they get edematous. So that is the reason why if you take the voice of these individuals, the voice, it becomes deeper, right? So it becomes, like the hoarseness of voice, like you will have a deep voice. Okay. And if you observe the hands and as well as the foot of these individuals with acromegaly, right? So you can see here the hand size, it is increased. Okay. And even you take this ring size, right? That is increased. And you take the breadth of the feet, they are increased. So thereby what will happen to your shoe size? Shoe size is also increased. Okay, so these will be the skeletal manifestations. And you take the soft tissue manifestations. So if you take the soft tissue manifestations, please remember this increased growth hormone will come and act on the skin. So what will happen to your skin fold thickness? So the skin fold thickness will increase, right? And what is that you have within the skin? You have the presence of the sweat glands. So there will be excessive or profuse sweating because of sweat gland hyperplasia, right? So because of the hyperplasia of your sweat glands, there will be increased sweating within these individuals. Now apart from that, right, apart from that, if you take the chest wall, even the chest wall thickness is also increased. right? The chest wall thickness is also increased. And whenever the individual lies in the supine position, that increased thickness of the chest wall will go and act on or will compress the respiratory tree. And thereby, whenever the individual sleeps in supine position, the individual will have cessation of respiration for a period of time during sleep. And that is the reason why it is called obstructive sleep apnea can also develop. And because of this particular obstructive sleep apnea, please remember there will be intermittent stimulation of your sympathetic nervous system, and that will make the individual to land up in the hypertension. So hypertension is one of the clinical manifestation in case of the obstructive sleep apnea. And remember, in acromegaly, there is also release of the excess growth hormone that will go and act on the internal visceral organs. So that will go and act on the heart, where the individual will land up in the cardiomegaly. And the other internal organs which gets increased in its size are lung, spleen, liver, and as well as the kidney. So there will be splenomegaly, there will be hepatomegaly, there will be renomegaly. So these are the internal organ abnormality what you will have in patients with the acromegaly. And not only the internal organs, you take even the joints, right? So the space between the joints will be reduced and there will be rubbing of the bones, and that will make the individual to develop what is called osteoarthritis. Right? That will make the individual to develop what is called osteoarthritis. And the next important thing is, you take nerve entrapment syndromes. We have a nerve entrapment syndrome which can occur in the carpal tunnel, where there will be compression of your median nerve. There can be a nerve entrapment within the tarsal tunnel, where there can be compression of your tibial nerve. So why is that? Again, same reason. There will be increase in the soft tissue within the median nerve. There will be increase in the soft tissue within the carpal tunnel, where you have the passage of your median nerve. So that will cause the compression of this particular median nerve, resulting in what is called the carpal tunnel syndrome. And there can be also increase in the soft tissue within the tarsal tunnel, and where the individual will have the compression of the tibial nerve, and that will result in tarsal tunnel syndrome. Right? That will result in the tarsal tunnel syndrome. So this is about, like soft tissue manifestations, what you will have in patients with the acromegaly. Next important thing is the cardiac anomalies. See, what is happening to your heart? There is increasing in the size of the heart. So now what will be that particular cardiac anomalies? See, the cardiac anomalies includes development of the cardiomyopathy. And which particular type of cardiomyopathy is very common? It is your hypertrophic cardiomyopathy. So hypertrophic cardiomyopathy is one of the very important cardiac anomalies that can be seen in patients with your acromegaly. Now, apart from hypertrophic cardiomyopathy, remember, in acromegaly there is the obstructive sleep apnea. So because of your obstructive sleep apnea, there is intermittent stimulation or intermittent increase in your sympathetic outflow, and that is the reason why the individual is having the hypertension. And the other important cardiac anomalies is the arrhythmias. See, very important point you should know in acromegaly is that, for example, if the individual dies in acromegaly, the most common cause of death, right? The most common cause of death in patients with acromegaly is due to congestive cardiac failure. Right? It is due to congestive cardiac failure. And remember, the other important cardiac anomaly is the individual can have accelerated atherosclerosis. Right? The individual can have the accelerated atherosclerosis. So because of this accelerated atherosclerosis, the individual can develop your coronary artery disease as well. So these are the cardiac anomalies: the hypertrophic cardiomyopathy, hypertension, arrhythmias, accelerated atherosclerosis causing or landing the individual to coronary artery disease, and finally the development of congestive cardiac failure. And once the individual develops congestive cardiac failure, that will make the individual to die. So most common cause of death in patients with your acromegaly is your congestive cardiac failure. Now, in the etiology, I have discussed one of the important cause for acromegaly is mammosomatotroph type of pituitary adenoma. So, if there is mammo-somatotroph type of pituitary adenoma, in mammo-somatotroph type of pituitary adenoma, there will be increase in your prolactin levels and there will be also increase in the growth hormone levels. Right? So there will be increase in both prolactin and as well as the growth hormone. So whenever there is increase in your prolactin levels, in females, they can have the menstrual irregularities. And this particular menstrual irregularities will be in the form of amenorrhea. Right, will be in the form of amenorrhea. And just now I was discussing the cardiac anomalies. The cardiac anomalies, they are present in almost 10 to 20% of patients with the acromegaly. Now, after having discussed about mammo-somatotrophs, so only in case of mammo-somatotroph type of pituitary adenoma, like you will have this menstrual irregularities in the form of amenorrhea if the female has this acromegaly. Next, the other important abnormalities is your metabolic changes. What is that metabolic changes? Please remember that growth hormone will increase the glucose levels. That is the basic physiology, right? That is the basic physiology. So this growth hormone, the basic physiology is that it will increase the hepatic gluconeogenesis. Right, it will increase the hepatic gluconeogenesis. So whenever it is increasing hepatic gluconeogenesis, in acromegaly, what will happen? In acromegaly, there is excessive increase in your hepatic gluconeogenesis. And thereby, in acromegaly, the individual will have what is called as impaired glucose tolerance in almost 80% of individuals, and in 13 to 20% of individuals, they can land up in diabetes mellitus. So in acromegaly, why they will have this particular secondary diabetes mellitus? That is because of the physiological action of the growth hormone. That is, growth hormone is a diabetogenic hormone. Growth hormone will increase the blood glucose level within the individual. Next, the other important thing is the headache and as well as the visual field loss. Now, why do you think that the individual will have the headache and as well as the visual field loss? Because in acromegaly, you have what is called macroadenoma. Right, you have what is called the macroadenoma. So this particular macroadenoma, it will cause the mass effect on the optic chiasma. And because of the mass effect on the optic chiasma, the individual will have this particular visual loss. And this macroadenoma, where the size of the tumor is more than 10 mm, it will also increase the intracranial pressure. And because of this raised intracranial pressure, the individual can have the headache. Right? The individual can have headache. Okay. So these are the clinical manifestations what you will have in patients with the acromegaly. And what did I tell you? The most common cause of death in acromegaly is your cardiovascular mortality. Right? It is your cardiovascular mortality. Now, apart from that, you should know what will be the gastrointestinal manifestations in patients with the acromegaly. In acromegaly, there is the colon manifestations. And what are those colon manifestations? These colon manifestations, they are in the form of the polyps. And not only that, these patients with acromegaly, they can develop a complication, that is your carcinoma colon. So these are the gastrointestinal manifestations. So what I will do, I will just summarize all the clinical manifestations of acromegaly. Number one, the local tumor effects. That is visual field effect, cranial nerve palsy and as well as headache. So local tumor effect you will have only whenever there is macroadenoma, where the size of the tumor is more than 10 mm. Again, if it is microadenoma, you will not have this particular local tumor effects. And as I have said you previously also, macroadenoma is more common than compared to that of the microadenoma. That is the local tumor effect. And you take the second important manifestation, that is somatic manifestation, that is the acral enlargement. There will be increase in the size of the hand and increase in the size of the foot. So because of increase in the size of the hand, there will be increase in your glove size and there will be increase in the size of the ring. right? Increase in the size of the ring. And because of increase in the size of the foot, right, there will be increase in the size of the shoe as well, right? And the other important thing is like the somatic manifestations, thickening of the soft tissue of the hands and as well as feet. And that is the reason why the individual can have even profuse sweating also, because of the sweat gland hyperplasia within the skin. Musculoskeletal manifestation, right? Within the face there can be forward protrusion of the jaw, that is your prognathism, and there can be malocclusion of the teeth, arthralgia, carpal tunnel syndrome. So carpal tunnel syndrome, it is your nerve entrapment syndrome where there will be compression of your median nerve, and the individual can also develop even tarsal tunnel syndrome where there is compression of your tibial nerve. And the next important thing is the frontal bossing, that is again your coarse facial features you will have in acromegaly. Then coming to your sleep disturbances, so there is increase in the soft tissue around the chest wall, right, and that will make the individual to develop then obstructive sleep apnea, right? So these patients, they will have a disturbed sleep all through the night, and that is the reason why they will have excessive sleep in the morning time, right? Excessive sleep during the daytime. So that is nothing but your narcolepsy. Skin manifestations, hyperhidrosis and as well as the skin tags. Hyperhidrosis is nothing but profuse sweating. The colon manifestations, I have said you, like polyps, and they can progress even to develop even the carcinoma colon. Cardiovascular manifestations, they can have left ventricular hypertrophy. And why do you think left ventricular hypertrophy? That is because of your hypertension. And these patients, I have said you that they will develop hypertension, and whenever there is hypertension, there will be increased afterload on the left ventricle, and that will make the individual to land up in hypertension. And at one point of time, they will also develop even your congestive cardiac failure. And the most common cause of death in acromegaly is the congestive cardiac failure. Visceral manifestations. You take the size of the tongue, like there will be macroglossia. Even your macroglossia is also responsible for your obstructive sleep apnea. Because of this macroglossia, the tongue can fall back over the trachea during the sleep, or the tongue can cause the pressure effect or the mass effect or the local effect on the trachea, where there can be compression of the trachea, and that makes the individual to land up in obstructive sleep apnea. And the other visceral manifestations are there is increase in the size of the organs like hepatomegaly and as well as the splenomegaly. And even there will be thyroid enlargement as well. Sexual function, mainly it gets affected if there is mammosomatotroph type of pituitary adenoma, like there will be menstrual irregularities in the form of amenorrhea, right, and galacturia in females, and there will be decreased libido in both males and as well as females. Because whenever there is increase in your prolactin, the prolactin will reduce the testosterone production, and that is the reason why there will be decrease in your libido. Then coming to the carbohydrates. So there is impaired glucose tolerance, insulin resistance, hyperinsulinemia, diabetes mellitus, hyperlipidemia, and as well as hypertriglyceridemia. Please remember, this particular dyslipidemia is also seen in other endocrine conditions. And what are the other endocrine conditions where you will have this dyslipidemia? You will have this in patients with the hypothyroidism, right? And you can have this in patients with the diabetes mellitus. So in diabetes mellitus also you can have this dyslipidemia, which is in the form of hypertriglyceridemia. So these are the clinical manifestations of the acromegaly, right? Local tumor effects, somatic manifestations, musculoskeletal manifestations, sleep disturbance, skin manifestations, colon manifestations, cardiovascular, visceral, sexual, and as well as the carbohydrate intolerance. Now finally, how will you diagnose, right? How will you diagnose your acromegaly? So always you need to do a chemical analysis in case of your endocrine disorders. So what is the first line investigation? The best initial test, right? The best initial test will be insulin-like growth factor 1 levels will be elevated. That is, there will be increase in your somatomedin levels. Please remember, patients with acromegaly have symptoms for an average of 9 years before the diagnosis is made, right? Because the symptoms, whatever you see in acromegaly, we don't focus ourselves, this could be acromegaly, right? Almost after 6 to 9 years, we come to a conclusion, this could be acromegaly, and we test for. So patients with acromegaly have symptoms for an average of 9 years before the diagnosis is made, okay? Now, so the initial test is what? The IGF-1 levels. So a significantly elevated IGF-1 levels, that is the one, it is a positive screening test for acromegaly. Right, which is a positive screening test for acromegaly. Now, apart from that, the other important investigation is the random growth hormone assay. Growth hormone secretion, it is always episodic. Right, growth hormone secretion, it is always episodic. And serum concentration of the growth hormone may fluctuate from undetectable levels to significantly high levels during the day. So that is the reason why we don't take the growth hormone assay or the growth hormone levels for the diagnosis of your acromegaly. So due to pulsatility of growth hormone secretion, measurement of single random growth hormone level is not useful for the diagnosis or the exclusion of your acromegaly. Right? So due to pulsatility of the growth hormone secretion, measurement of single random growth hormone level is not useful for the diagnosis or exclusion of the acromegaly. So what is the initial test? That is your insulin-like growth factor levels. Insulin-like growth factor 1, that is somatomedin levels, are elevated. But that is only a screening test. But what is a confirmatory test then? The confirmatory test is the growth hormone suppression test, where there will be failure of the growth hormone suppression in response to your glucose load. So normally glucose load, right, normally the glucose load should suppress the levels of the growth hormone, right, should suppress the levels of growth hormone. And measurement of your insulin-like growth factor or somatomedin correlates with the disease activity. Please remember this point. More is your somatomedin levels, more severe is your acromegaly. Then coming to your growth hormone suppression test. Normally whenever you give a glucose load, the growth hormone levels should suppress. But in acromegaly, there is failure of growth hormone suppression in response to your glucose load. So that will confirm the diagnosis of your acromegaly. So once you confirm the diagnosis of acromegaly, the next important thing is your radiological study. So what is that radiological studies you have to do? You have to do MRI or CT scan. That is mainly to localize the tumor. That is mainly to localize the tumor. But remember, MRI, it is more superior than compared to that of your CT scan. Right? MRI is more superior than compared to that of your CT scan. Right? This MRI will show a tumor in almost 90% of patients with the acromegaly. So this will be the radiological studies. So if you see the management in the patients with the acromegaly, the basic objective of the treatment is mainly to decrease the growth hormone levels and to decrease the tumor size. Thereby the mass effect can be reduced and to preserve the normal pituitary function. So that is the objective of this particular treatment of acromegaly. That is mainly to decrease, right? That is mainly to decrease the growth hormone levels, to decrease the tumor size, right? And as well as to preserve the pituitary function. And what is the treatment of choice in case of acromegaly? The treatment of choice in case of acromegaly is surgical resection of the tumor. Right? So this particular surgical resection, it is transsphenoidal surgical resection of the tumor. So surgical resection of the tumor, please remember the individual will have a rapid response on the surgical resection. And but when you do a transsphenoidal surgical resection of the pituitary, in almost 10 to 20% of individuals, there can be development of your hypopituitarism. But please remember the primary treatment is the surgery. And in those individuals where the surgery cannot be done, what will be the second line management? The second line management will be the drugs. And within the drugs also, what is the drug of choice? the drug of choice will be your somatostatin analogs. And these somatostatin analogs, the examples what we have is octreotide and as well as the lanreotide. So this octreotide and as well as lanreotide, they will reduce the growth hormone levels. Right? They will reduce the growth hormone levels in almost around 70% of patients. And these lanreotide and as well as octreotide, they will also reduce the tumor size. So they will reduce the tumor size in, right? They will reduce the tumor size in 20 to 50% of patients. And out of this, you take this octreotide. Octreotide is the best medical therapy for acromegaly. And what will be the adverse effects of your octreotide and lanreotide and all that we will discuss. But let me first take up the discussion related to your somatostatin analogs in detail. So what are these somatostatin analogs? That is your octreotide and as well as lanreotide and as well as the paceriotide. So these are your somatostatin analogs. And these somatostatin analogs, they exert their therapeutic effect through receptors. Like this octreotide and as well as lanreotide, they exert their effect through SSTR2 and as well as SSTR5 receptors. And both of these receptors, right, both of these receptors, they are expressed on the growth hormone secreting tumors. Whereas you take this paceriotide should be given for those individuals who are resistant to octreotide. The individual has no response with the octreotide. That is the point when we give this paceriotide. So this paceriotide, it has preferential SST5 binding, and that has been shown to exhibit the efficacy. So the efficacy of paceriotide is more than compared to that of your octreotide. But usually we prefer to give paceriotide when the individual is resistant to this particular octreotide. Next. Now, if you take the discussion related to the octreotide, it is an 8 amino acid synthetic somatostatin analog. So it is 8 amino acid synthetic somatostatin analog. And in contrast to your native somatostatins, in our body also, there are somatostatin which is being produced from your hypothalamus. In contrast to the native somatostatin, the somatostatin analog, it is relatively resistant to plasma degradation. Right? It is resistant to plasma degradation. Okay, so that is about the octreotide. And what is the half-life of these particular somatostatin analogs? It has 2.5 serum half-life and possess 40-fold greater potency than native somatostatin to suppress the growth hormone levels. I said you in the regulation, somatostatin is produced from the hypothalamus that will go and inhibit the growth hormone secretion from the anterior pituitary. So it has 2 hours of the serum half-life. Okay, and it has 40-fold greater potency than native somatostatin to suppress the growth hormone production. And what is the dose and what is the route of administration of your octreotide? So this octreotide, please remember, the route of administration is the subcutaneous, right? It is given in the form of subcutaneous injection. And the dosage of this particular octreotide is 50 micrograms thrice daily, right? 50 micrograms thrice daily. and the dose can be increased gradually even up to 1500 micrograms per day can be given depending upon the response of the individual. And what this octreotide will do? This octreotide will suppress the integrated growth hormone levels. Right? Will suppress the integrated growth hormone levels and normalizes the IGF-1 level in almost 60% of the treated patients. Right? Normalizes the IGF-1 levels in 60% of the treated patients. So that is what is the mechanism of action of the octreotide. And what are the various formulations you have of this octreotide? See, we have long-acting somatostatin depot formulation, and these depot formulations, these are long-acting, right? These are long-acting. So these depot formulations you have of both octreotide and as well as even your lanreotide. So this lanreotide, so these two are the preferred medical treatment for the patients of acromegaly. This octreotide long-acting release preparation, it is a sustained release long-acting formulations of octreotide which is incorporated into microspheres. So this octreotide long-acting release, which is a sustained release preparation, which is a long-acting formulation, it is incorporated into microspheres, right? That sustain, these microspheres are the one which will sustain the drug levels for several weeks after intramuscular injection. Actually, I have said you that octreotide is given through subcutaneous route, but this long-acting release preparations, they are given through the intramuscular route, and whenever you are giving through the intramuscular route, the duration of action will be for several weeks. Right, the duration of action will be for several weeks after the intramuscular injection. And whenever you are giving this particular preparations, what is that particular several weeks? What is that long duration? Growth hormone suppression occurs for as long as 6 weeks. For almost like 6 weeks, the growth hormone suppression can be there after 30 milligrams of the intramuscular preparation. Right? So what is the dosage? 30 milligrams of your intramuscular preparation. So this is what is your long-acting formulations of your octreotide. Whereas you take lanreotide. So regarding the lanreotide, we have the lanreotide autogel. This lanreotide autogel, it is also a long-acting preparation. It is a slow-release depot somatostatin preparation. Right? And it is a cyclic somatostatin octapeptide analog that suppress the growth hormone, that suppress the IGF-1 hypersecretion after 60 milligrams of the subcutaneous injection. So long-acting preparation of your octreotide intramuscular, long-acting preparation of your lanreotide autogel, the route of administration is the subcutaneous route. So this long-term administration control the growth hormone hypersecretion in about 2/3 of patient and improves the patient compliance because of long interval required between the drug injections. So this particular lanreotide can also suppress the growth hormone levels for nearly around 4 to 6 weeks. So you have long interval between the drug administration. So because you have a long interval between the drug administration, the compliance can be improved, right? The compliance can be improved. And whenever you are giving these particular preparations, there will be a very rapid relief of the headache, right? There will be rapid relief of soft tissue swelling, right? Rapid relief of headache and as well as soft tissue swelling in almost 75% of patients within days to weeks of somatostatin analog initiation. And most patients, they report symptomatic improvement, like there will be decrease in the headache, there will be decrease in your hyperhidrosis, that is sweating, there will be decrease in your obstructive sleep apnea, and there will be also decrease in your cardiac failure. And what did I tell you? In those individuals who are resistant to your octreotide, you need to give paclitaxel, right? And this paclitaxel, it has preferential SST5 binding that has been shown to exhibit the efficacy. Then coming to your side effects of your somatostatin analogs. See, most of the patients, the somatostatin analogs, they are well tolerated. But certain group of individuals, they will develop these adverse effects, and these adverse effects, they are short-lived. And what are these adverse effects? The adverse effects are short-lived, and mostly they are related to drug-induced suppression of drug-induced suppression of gastrointestinal motility and drug-induced suppression of the secretions. So GI side effects are common with your somatostatin analogs. So because of drug-induced suppression of gastrointestinal motility and as well as the secretions, what will be the adverse effects? There can be nausea, there can be abdominal discomfort, right? There can be abdominal discomfort, right? There can be also fat malabsorption, right? And because of the malabsorption, the individual can have diarrhea, right? The individual can also have the flatulence, right? The individual can also have flatulence. So these are the adverse effects, but these are short-lived. And these particular adverse effects, they are mainly because of decrease in the gastrointestinal motility and as well as decrease in the gastrointestinal secretion. Okay, and short-lived in the sense they usually remit within 2 weeks, right? They usually remit within 2 weeks. And mainly you take this octreotide. Octreotide, it suppresses the postprandial gallbladder contractility. See, immediately after taking the food, once the food enters into the stomach and as well as the duodenum, the gallbladder will contract and will release the biliary secretions into the second part of the duodenum. But what this particular octreotide will do? This octreotide, it will reduce the gallbladder contractility. So thereby what will happen? There will be delay in the gallbladder emptying, and because of that there will be accumulation of the biliary secretions within the gallbladder, and that will make the individual to develop what is called cholecystitis. Right, so cholecystitis is one of the adverse effects associated with your octreotide. So please remember, octreotide suppresses the postprandial gallbladder contractility and it will delay the gallbladder emptying. In almost up to 30% of patients, they develop long-term echogenic sludge or asymptomatic cholesterol gallstones. So initially they can have cholecystitis and subsequently there will be development of the gallstones as well. And what are the other side effects? So the other side effects, they include mild glucose intolerance that is due to transient insulin suppression that can be done by your octreotide. And there can be asymptomatic bradycardia, hypothyroxemia and local injection site discomfort. So these are the adverse effects which can be seen with your octreotide. Whereas you take paclitaxel, it is associated with high prevalence of glucose intolerance or new onset diabetes mellitus. But with your octreotide and as well as lanreotide, it is the mild glucose intolerance. But with paclitaxel, right, which is a new somatostatin analog, there is a very high prevalence of development of the new onset diabetes mellitus. Okay, so that is about the octreotide analogs, which is the first line treatment for the first line drug treatment in case of acromegaly. But if the question is asked like what is the first line treatment, it is transsphenoidal surgical resection of your pituitary gland if it is somatotroph type of pituitary adenoma. But first line drug treatment will be your somatostatin analogs. Now apart from the somatostatin analogs, the other drugs that can be given is the dopamine agonists. These dopamine agonists should be given mainly in the individual with somatotroph type of pituitary adenoma. So in those individuals where there is somatotroph type of pituitary adenoma, there we give this particular bromocriptine and as well as cabergoline. Right? They are used if the surgery is not curative, and almost 10% of the patients they respond to this particular drugs. Now, apart from this somatostatin analogs and dopamine agonist, we also have what is called as growth hormone analog that antagonizes the growth hormone receptors which are present in the liver, and that is nothing but your pegvisomant. So please remember this pegvisomant, it is a second line agent, right? It is a second line agent. Which one? Your pegvisomant. It is a growth hormone analog. Right? It is a growth hormone analog that will antagonize endogenic growth hormone by blocking peripheral growth hormone binding to its receptor in the liver. What this pegvisomant do? Pegvisomant will go and bind to the receptors which are present in the liver. Right? And thereby growth hormone cannot bind to its own receptors which are present in the liver. So this pegvisomant, it will be acting as the competitive agonist for your growth hormone receptors which are present within the liver. But remember a very important point, that pegvisomant, it is always a second line. And apart from your drug treatment, the next important treatment modality is your radiotherapy. Radiotherapy is used only if surgery and drug therapy do not work. That is the point when you need to give radiotherapy. Right? This radiotherapy, it will cause slow resolution of the disease, and hypopituitarism is seen in almost 20% of patients. So this is about the treatment of acromegaly. So to summarize the treatment of acromegaly, right? If it is a growth hormone secreting adenoma and you assess the likelihood of surgical cure, if there is high likely of the surgical cure, then you do a surgery and then take out your pituitary gland. Then after that, you measure the growth hormone and as well as the insulin-like growth factor 1 levels. If it is controlled, very good. You just monitor. That's all. If it is still elevated, that means in spite of doing surgery, the levels are still elevated. That is the point when you can give your somatostatin analogs, that is your octreotide or lanreotide or pesireotide can be given. Right? Now, for example, if the individual is unlikely for the surgical cure, then you need to give the somatostatin analogs. After giving somatostatin analogs, please measure the growth hormone or the insulin-like growth factor 1 levels. If it is controlled, just monitor. And if it is uncontrolled, in spite of giving the somatostatin analogs, if it is the levels are still uncontrolled, then increase the dose or the frequency of your somatostatin analogs, or you can add growth hormone receptor antagonist or add the dopamine agonist. So in spite of adding somatostatin analog, in spite of increasing the dose of your somatostatin analogs, if the growth hormone levels are still high, then you can add this growth hormone receptor antagonist, that is your pegvisomant, or you can add the dopamine agonist, that is your bromocriptine or cabergoline can be added. So after adding this, you measure the growth hormone or IGF-1 levels, and if it is controlled, then monitor, and if it is uncontrolled, then you need to do radiation therapy. So first line treatment is surgery, next is your medical management, and next is your radiotherapy. And finally, you should know what are the complications of your acromegaly. The complications of acromegaly, they can arise from pressure of the tumor on the surrounding structures or invasion of the tumor into the brain or the soft tissues, right? So the complications are mainly because of your pressure effect on the surrounding structures or invasion of the tumor into the surrounding structures. Right? Invasion of the tumor into the surrounding structures. Now, what are these complications? These complications, please remember the cardiac failure. The most common cause of death in acromegaly, it is your congestive cardiac failure. The next important complication is diabetes mellitus. Please remember, in patients with your acromegaly, the individual will have the hyperglycemia. There is glucose intolerance, and in almost 20% of individuals, they will develop diabetes mellitus. Why? Because your growth hormone is a diabetogenic hormone. And there can be increase in the size of your vertebra. Breadth of the vertebra can be increased, and there can be narrowing of the spinal canal, and that can cause the cord compression. And because of the mass effect on the optic chiasma, the individual can also have the visual field effects. So these are the complications in patients with your acromegaly. So to summarize acromegaly, it is a clinical condition where there is increase in your growth hormone after the fusion of the bones. Most common cause, somatotroph type of pituitary adenoma. And what type of pituitary adenoma? Macroadenomas are very common. Clinical manifestations, you will have both soft tissue manifestations and as well as the skeletal manifestation. And first line investigation, IGF-1 levels. Confirmatory test, failure of your growth hormone suppression in spite of your glucose load. Then MRI of the pituitary gland. The first line treatment, surgical resection of the pituitary gland. First line medical management, somatostatin analog. Not responding, then you add dopamine agonist and the pegvisomant. Not responding to your surgery or medical management, then you do radiotherapy. Then these are the list of the complications what you need to know in the acromegaly. So this finishes the topic of your acromegaly. Thank you very much.